Okay, really excited to welcome you all to this evening's event. It's the last of the succession of events that we've been having for Annual Appeal Month and recognition of all of the work that's going on around New Zealand supporting research into all sorts of different neurological conditions. Just a little bit, if you haven't heard of the Neurological Foundation before, our purpose is to do two things. Firstly, to raise awareness around neurological conditions and the importance of understanding those in the community. And secondly, a lot of the work that we do is actually funding research into all sorts of different conditions, both here in Auckland, Otago, AUT, Canterbury, and all around the country. As you may know, neurological conditions are not selective. They can impact anybody. 1 in 5 at least people will be impacted at some stage, and often it's even more than that if you think about things like migraine, etc. And all of the work that we do, the funding that we gather for research, is all from donations from New Zealanders. We don't have any government funding at all, so it all comes from the wonderful, generous support that we get from many of you in the room and many, many people all around New Zealand. So a huge thank you from us for all of your support to help many of the researchers along the way. We were formed nearly 50 years ago, and as an organisation, we've been working through and revisiting how we best meet the needs of research, how we best meet the needs of growing future researchers, future neurologists around the country, because the diseases aren't going to go away, and our challenge is if we don't start investing in the skills now, as Peri, our board chair, was talking about the other day, it takes 25 years to grow a neurologist and then another 25 years to replace them, and they need to have those skills along the way about how important research is as well. Over the last 5 years, we've been able to fund over $13 million of research across New Zealand, which we're really proud about. However, at the same time, we've had applications for research, for fellowships and scholarships, somewhere in the order of $40 million, and we haven't obviously been able to afford to fund all of those. So recognising that the demand for research is growing and growing. We also support a couple of other key capabilities. So in this wonderful building, we have a relationship with Sir Richard and Morris and the Neurological Foundation Human Brain Bank. We just renewed that last year for another 5 years. And this year we're celebrating the 25th anniversary of that relationship, allowing researchers to actually use real human brain tissue to help them with their research. And the other relationship that we also just renewed last year is the Chair of Clinical Neurology, Professor Alan Barber, and the work that he and his team are doing around clot retrieval for stroke patients and then the recovery programs that sit in behind that. So just really wanted to thank you all for the support that you've given us. I hope you really enjoy this evening, have lots of really exciting questions for Lynette and the team. So I'll hand over to Lynette.
Thank you, Rich. So this begins the panel part of the evening, but I first just want to offer apologies from Dr. Phil Wood, who was going to be on the panel tonight. He had a family incident which meant he was unable to come, so he sends his apologies, but we're very lucky to have Dr. Kathy Peri, who's come along to join us at short notice. Before we start fielding questions from everyone in the audience, I'm just going to ask each of the panellists to just give a really brief introduction so you've got a sense of their interests and expertise.
Can we just...
Oh, what? Sorry, this is Dr. Ngaire Cheung on my left first. He's an academic old age psychiatrist who has a joint appointment in the University of Auckland and Auckland DHB.
We all know each other quite well, so that's one good thing on the panel. Good evening, everyone. So I'm a psychiatrist, and I was just thinking while you were talking before, I started my psychiatry training 20 years ago in Hamilton. I always loved working with older people, and memory issue is one of the common presenting issue for our older people. And my clinical work it's from people with very early memory complaints to people with very severe dementia in dementia care. So one of the last thing I did before I left Hamilton 12 years ago was involved in a memory clinic, starting up a memory clinic in the Waikato. And now I work with Lynette in the Dementia Prevention Research Clinic. I work with Kathy as well. She will talk about some of our research, and Ngaire as well, learning about research and dementia prevalence study.
I'm going to stand up. Tēnā koutou katoa. I'm Ngaire Kerse, and I'm a GP by background. Born in the South Island, grew up in a big family, and I got really interested in older people because my grandma got to be 95. And we thought that was fantastic. She had this huge garden in Motueka, and she was a very active, very hard-working woman. And so I thought you had to work hard to get old, but I'm not sure that's entirely correct. But I got interested in things to do with brains and with memory because as a GP, it's an enormous privilege to spend your time following people through, being there for the times in their lives when things change. And stuff happens to them. And part of it is neurological and part of it is memory related. And some people never get those memory problems. So the intriguing thing for me was just looking at the huge variety of how people do things. When I started to do research, I was very interested in falls prevention. And of course, falling over is something we all do. Hands up who's fallen over in the last year. Probably, yeah. Many of you, yeah. Most of you will have gotten up. But as you get older, you don't get up so easily. And so I realised after a while that as you're walking along, you can walk along quite fast, but then when you talk to your neighbour, do you slow down or not? You've got lots of things going on here. You're walking, you're navigating, and then when you're talking to someone else, you're using a different bit of your brain and you're distracting yourself. And so I started to think about how the brain and the body work together, and obviously they do. The neurologist taught me that when I was in medical school. But the intricacies of how that works is really fascinating, and I would like to try. And then, so of course, once I realised that happened, I thought, well, why don't we train people by doing 2 or 3 things at once, or 4 things at once? Let's really get people stimulated and confused. So I'm really interested in research, trying to prevent dementia. I'm really interested in how people live their lives and how carers look after people with dementia and how to make that easier. So it was more than my 5 minutes, sorry.
That's because I'm a bit nervous. And look, I'm Peri, and giving me a microphone might be a bit dangerous. I might go past my 5. But anyway, look, I've got a nursing background, and for all my nursing career, I have been working with older people. And clinically, I've worked many years as a clinician, and my research background came a bit later in life, but all the questions that I had around looking after older people in age residential care and the community triggered my interest in carrying on and doing research. So I've done a lot of research in a lot of different areas. However, and I've always worked at, I don't want to mean at the spectrum where people say, why is that person behaving like that with their dementia? And I say, well, actually, you're challenged, not the person with, because, I don't know if you realise it, they call it the challenging behaviours of people with severe dementia. It's actually they're challenging us to actually think about them in a different way. But actually, more recently, I've been very excited, and that I've been doing some research around the mild to moderate, people with mild to moderate dementia. And myself and Dr. Cheung here, we've been instrumental in doing some research around non-pharmacological interventions. Because we know physical activity is really important for the brain, but we also know cognitive function activity is also just really important as well. And it's important when you get dementia as well, to actually do something about that. And so Ngaire and I have been, for the last 4 years, implementing cognitive stimulation therapy into New Zealand. And so I'm happy to, it's just a little bit about the intervention, because you probably all think, well, what does that mean? Because, oh, can I have it? It's actually a short intervention of 7 weeks, twice a week for an hour at a time, and it's for and they come together as in a group of 8 people, and there's a facilitator, and we use the theories around reality orientation, validation, and reality orientation and reminiscence, and that's the basis of the intervention. So I'll leave it for there. I'm sure you'll have lots of questions around that and others. So thank you, Lynette.
Thank you, Kathy. I'll stand up. I'm a psychologist by trade, and in particular, my speciality is neuropsychology, and what that means is I work with trying to assess people's memory and other thinking abilities when there's some concern that there might be a problem with some aspect of brain functioning. So we're looking at how that might be affecting how well people can think. So this might be as a result of something that's happened to people. They might have had a fall, a traumatic brain injury, they might have had a stroke, or it might be because there's concern that there's a developing progressive condition such as Alzheimer's disease or another dementia. So I'm involved clinically in that aspect of trying to sort out what is happening, and a really important part of that is being able to understand what is normal memory function as we age, and when are those changes in memory more than you would expect with normal aging. And that's a really tricky question, because many people, many of us here, will realise that our memory's no longer just not quite as good as it used to be. Might be better in other ways, but most people notice changes in what they can remember, and that's normal. So what is abnormal? That's one of the big questions. So my current research is largely tied up with the Dementia Prevention Research Clinic, which Ngaire mentioned just before, which is a research clinic funded by Brain Research New Zealand and is also part of the Centre for Brain Research. The Auckland Clinic is based here in the Faculty of Medical and Health Sciences, and we're working primarily with people with a condition or a description, if you like, called mild cognitive impairment. So mild cognitive impairment refers to people who do have a significant problem with their memory. It is worse than it should be for their age, but they are nevertheless functioning fine in everyday life. And we want to know, we want to be able to tell what makes some of this group, which is at higher risk of dementia, develop dementia, but more importantly, what is it that stops other people from progressing to dementia? What can we do to stop the progression into that kind of condition? So that's our focus. And so people in the clinic are part of a range of studies, but hopefully also a set of intervention studies that look to trial different possible interventions that arise from research. So that's the 4 of us, so we span a reasonable amount here, and what I would like to do is just open the floor up for questions.
Good evening. My name's Vivian. I have a question. I'm not sure to who to direct it. I've read that there is a connection of loss of hearing to cognitive decline, and that it's imperative for people who lose some hearing to get hearing aids. And yet I noticed amongst my age group not many people have heard about this. So please, I'd love to hear your comments.
That's a really interesting question, and it's actually a topic that I think has really only been talked about greatly in the last couple of years. So in a very large study looking at risk factors for dementia, hearing loss, especially uncorrected hearing loss in the middle years, is a risk factor for the development of dementia. That doesn't mean, let me hasten to say, that if you've got hearing loss you will develop dementia, but people are at elevated risk. Now we don't, to be honest, the research isn't clear yet about why that is the case. there are a number of possible reasons. It could be that people, who are not hearing well, especially if they're avoiding getting hearing aids, and I agree there is much more avoidance around hearing aids than glasses. It could be that what actually happens is they're interacting less and they're therefore becoming slightly more socially isolated and just not getting the stimulation. Or it could be that as part of the hearing loss there are changes that are associated with that in the brain. We're just not sure yet. So yeah, get your hearing checked and wear those hearing aids.
You have made mention of physical activity as being a requirement to ward off aspects of dementia. Has any research been done on the degree of that physical activity? And as an example, some people will walk around the block and they consider that physical activity. On the other end of the continuum, you've got people who work out very robustly at the gym. Is the more robust the activity of greater benefit?
I'll have a go at that one. So the research is mixed. It's not entirely clear, but we're beginning to understand, yes, activity is very important. So vigorous activity is good, but of course you need to do that in a safe way, and the amount of activity is important. So you can build up your activity by having snackercise, as they say, 5 minutes of intensive here when you're biking up the hill and another 15 minutes of walking briskly. You don't have to go and do an hour all at once. But the other interesting thing, I have a PhD student who just did a review about this. She's very interested in cognitively challenging physical activity. So now what would that be? Well, I would say that playing soccer is much more cognitively challenging than walking on a flat surface. Also, walking on uneven ground and going hiking in the woods is much more cognitively challenging than just going for a quiet walk in the afternoon. So put some cognitive challenge in it, I would say. And you can work out how to do that. When we do research, we do it in a really boring way. Like you're on a treadmill and you're saying, sums from 100 back, counting backwards by sevens. That's not what I'm talking about. I'm talking about stuff where there might be social activity with it. So you have to talk and do your activity. So you're using as many bits of the brain as you can. So exercise is important. Yes, do as much of it as you can, but make it quirky, make it difficult, and make it fun.
Just to add to that is doing exercise with someone, because there's a lot of research out there talked about loneliness and how loneliness can impact on our life expectancy, development of dementia. So find a good friend you can do exercise with.
Thank you. Is there a difference between mild cognitive impairment and early onset dementia?
Yes, there is a really big difference. That term, early onset dementia, refers to dementias. Well, one definition is that emerge before 65, but actually it's really a group that emerges even younger than that. So people with early onset dementia may get it anywhere between kind of 40 and 60 really. And very often that type of dementia may have a genetic underpinning to it. Mild cognitive impairment is just a description of a person with a significant memory impairment. Doesn't matter. It's used in relation to people who are older, so 55 and older, and that group of people is at risk of progressing to dementia, but not all of them do. So it's quite different from, early onset dementia, which is referring to the younger age group who is developing an actual dementia that's diagnosable, if that makes sense.
Okay, is this on? Yeah. I have a daughter who has epilepsy, and she has the normal memory problems that one often gets with epilepsy. She's now in her 40s. Is this likely to increase her chances of developing dementia, or Is it...
It's a good question.
It is a good question, and I realise that I actually don't for sure know the answer to that. I myself have not read of any study where that's been highlighted as a risk factor for dementia. If people have temporal lobe epilepsy, I'm not sure if that's what your daughter has, then very often that arises from a part of the brain that's involved in memory that's not functioning well or is shrunken. That doesn't mean, though, that whatever caused that part of the brain to be shrunken is a progressive condition. I would say, but this is not to scare you, but just I think different people have different amounts of resilience when they face the effects of normal ageing. So someone who already has some problems with their memory may just notice when they get older that their memory is worse. But to the best of my knowledge, it doesn't come up as a risk factor for dementia per se. Do you want to add something, Barry?
Barry's good.
Okay. Barry Snow says that's okay.
My question is, do you think it's possible to learn without a short-term memory, and do other animals have a short-term memory?
Depends what you're meaning by short-term memory there, I guess. When I think about memory, like in studies of human memory, we have what I would call working memory, the ability to hold stuff temporarily in our minds and think about it and do stuff with it. And that then is either sort of transferred, if you like, into a longer term store or not. Not everything we think about is transferred into a longer term store. But that goes into something that we think of as episodic memory, our memory for events. Whether or not, and those events are things that we're able to relive and re-experience, whether or not other animals have that same capacity is actually a huge debate. There's some evidence from some species that they do. All those parts of memory are kind of critical for remembering, I think, as we understand remembering as humans. And we can have impairments in all sorts of different bits, and it produces a slightly different pattern of problems.
Hi, I was wondering if you guys could talk a little bit more about your research and what things you guys are exploring and any key findings, especially the non-pharmacological therapy thing.
Oh, yeah. So basically, the research that we've been conducting in cognitive stimulation therapy, we've extended that and included physical activity. So we're doing some research around physical activity and cognitive stimulation therapy as a joint research program. We're also doing cognitive stimulation therapy and sitting yoga, thinking about the benefits of that. Someone thought that initially that the older people would be lying on the floor during their yoga, but actually no, we're doing the sitting yoga because there's some evidence to show that sitting yoga will actually be beneficial. So we're also doing some research. We're taking that beyond that because we're getting to the point now, what else can we add to cognitive stimulation therapy? So we're actually now starting to look at cognitive reablement. And making that a little bit more like, you're aware of physical reablement, or actually going to start a project around cognitive reablement. So setting goals, using the activities of daily living and function to actually hopefully improve their memory. And most important for us is actually improving quality of life. So everything that we do in relation to our non-pharmacological interventions is actually about quality of life. Because that's the most important thing that people with dementia tell me that's important. So Ngaire, you got something to say about that?
Oh, how long have you got? So, I guess the most fun research that I've been doing is this trial of the Ronnie Gardner method. Sounds like a contraceptive, but it's not. It is, Ronnie Gardner is an 80-year-old jazz musician who dreamed up a program which he was interested in for people with stroke and Parkinson's disease. And it is, I've done it at Brain Day, and I've done it a few places. We had Christina Zawali who did her PhD about it. And so it is a thing you do to music where you get together in a group, and there's a facilitator there, and they teach you a new language. So you have different names for different body movements. It's a lot of cross-body movements, a lot of slapping and clapping and doing things, and it's all to music. And it's been shown to be very helpful for people with Parkinson's disease, because you can see there's a lot of cueing and a lot of action there. And people with stroke, even 5 years after the stroke, there's been some improvements from people who engage in this. It's very cognitively challenging. It's like training them with a Stroop test, actually, if you want to. So there's different colours and different words, and you have to follow along. So we're actually getting Ronnie Gardner to come to New Zealand in June and train some people. So if there's anybody in the audience who wants to train and learn to be a trainer in the method and then take it out to different community groups, please come and see me afterwards. So that's one really exciting thing, the Ronnie Gardner method. And another thing is with people in residential care. So I'm really passionate about care homes. So we've got a great program where we're doing some exercise therapy for people with dementia to try to stop them falling over, but at the same time we're going to look at their gait. So again, in that aspect of how your mind and your body will work together, looking at with accelerometers, wearing the accelerometers in the rest home for a week, look at the pattern of activity, how much activity there is, look at the details of the gait, where how stride to stride variability, those complicated things that people want to look at. And so to try to put it all together, as the brain changes, how does the gait change? As we train people in exercise which involves strength and balance retraining, how does that reflect in their gait, and how does that reflect in their cognition? But all in the care home. So we're very excited about that, and that's ongoing. Always happy to talk to people about research.
I can just yell, I've got a loud voice. My name's Annabelle, and I'm a physiotherapist over at... Okay, I'll even be louder. I'm a physiotherapist at North Shore Hospital and working in the older adult sector. How do we get our patients with the kind of more mild cognitive impairments involved in all of this research or clinics? And I mean, a lot of them are involved in the memory clinics, but the research side of things, or the rest homes, how do we know who's involved in the research, and how can we, use our knowledge and awareness of these programs to get more people involved?
I mean, ideally, we should have a database, and people can look up or phone someone to find out about these research. The first question about people with mild cognitive impairment getting involved in research, come to talk to Lynette about the Dementia Prevention Research Clinic as recruiting people with mild cognitive impairment. So we don't think we have any pamphlets here, but certainly we can get your details and send those to you. Yeah.
Right, there's a Brain Research New Zealand website, and you can just look that up and you can go to the clinics and see about the process. So yeah, you're most welcome. We're looking for people.
If you're interested in the cognitive stimulation therapy program, Dementia Auckland, if you contact them, they are actually delivering the CST as a program around, and also Enliven.
What role, if any, do you think the reduction in sleep duration and sleep quality in older adults has on their progression of memory loss?
Okay, so actually there's a fantastic sleep researcher in Wellington, Rosie Gibson, who's just written papers about this. And there is a direct link between quality of sleep and lengths of sleep, and particularly as sleep gets fragmented and the sleep delay phases, that really interferes with your circadian rhythm and Potentially, I don't know whether it causes cognitive decline, or as cognitive decline gets worse, the combination of those things makes life worse for the person with dementia and their carers, obviously, because that sleep is very important. Now, how you get people to go to sleep, I don't know, but don't give them drugs is the answer to that. No, the drugs actually compound the sleep problems to make memory problems worse. So lots of exercise in the morning when the sun's up. That sun on the back of your retina stimulates the pineal gland to make some melatonin at the right time. So exercise in the morning is one simple thing that everybody can do. Compound the sleep problems to make memory problems worse.
What about forgetting words in the middle of a sentence? What if it's bad enough to really affect your fluency sometime? Is it a sign of dementia, early dementia? Because there's going to be a lot of people with dementia if it is.
What was that?
Word finding. Word finding is a common problem in normal ageing. So most people, as they get older, will find the word they want is just not there in the middle of the sentence they're wanting to say. So it does not mean you're on the way to dementia.
Thank you. Okay, so that was the question was that you saw a YouTube clip of an elderly woman walking down the corridor with two helpers. Then they turned on some music, which was a military music, and she immediately started to walk more easily. Yep, and marched down the corridor. So that's, I can't talk about the neuroscience of it, but it's very common and it's very useful, particularly for people who are a bit anxious and also for people who have Parkinson's disease to have that cue to go to. And there's also quite a lot of reminiscence because probably she might have been a marching girl when she was a younger person and so off she went. My daughter's a good story. My daughter who is a singer, when she was doing singing at high school, she went and trained up and sang at a rest home. And her teacher was very clever and taught her all the songs from the 1950s and 40s. So there she was singing away. And these little old ladies who had severe dementia and really seldom spoke, they just sung all the words all the way through. And they were, word perfect and in tune. So there's different mechanisms and connections in your brain for different parts of how we operate.
What about diet? How can the diet prevent or make it less dementia?
Blueberries, beetroot.
Well, what's good for your heart is going to be good for your brain. So the Heart Foundation's done a wonderful job telling us how many vegetables a day? 5. Follow the heart diet. That's my recommendation. A good nutrition certainly helps with brain function. I mean, I have lunch since 12. I'm feeling a bit hungry. My brain doesn't work as well, so you all know that.
There's also some really interesting research around the Mediterranean diet. So if you're interested in reading some of that literature, there's certainly some evidence to show that might be actually a protective factor. There's some studies in Europe and some villages in Italy and in Greece that show that can actually make a difference to how it acts as a protective factor. So we might still have a chance. There you go.
What about a more alkaline anti-inflammatory diet? How does that relate to the brain and does that prevent neurological disease?
There is a role of inflammation in the development or part of the mechanisms that are going on in the development of the changes that occur with Alzheimer's disease. I'm not aware that there's any evidence that a alkaline anti-inflammatory diet moderates that, but then again I'm not sure that research has been done either. So we know inflammation's a critical part of the cascade of events that's occurring in the brain. I don't think we're yet sure of how to intervene with that.
Hi. As sort of recently, we've sort of seemed to have a lot of research in regards to concussion during sporting accidents. And apparently, if it's right, accurate, when you had several concussions, each one compacts on the prior one. So is that right? And I wanted to also ask if several concussions end up in a neurological, like a sort of a neurological pain in the nerve pain in the head, after 10 years, does that ever go away?
I can comment on the concussion. Actually, mild concussion is still, I'd say, reasonably controversial, and there's some people who will say that with a mild concussion you can get complete recovery. But mild concussion's a very broad spectrum, and it ranges from very mild through to people who are, are knocked out and have a significant blow. And there is some evidence that you can get accumulating effects. I would think of them as like a drop in the resilience of the brain, the more concussions that you have. Are you asking about the link between that and dementia or not?
I'm asking the link between that and neurological pain.
The link between that and neurological pain.
That just doesn't go away. And yeah.
I don't think I can't answer that, but I do know that you know that the brain has the capacity to do neurogenesis and replace damaged cells. And so, but after you've had a brain injury, it sometimes takes a long, long time to you have to rest it. And resting the brain is almost impossible. So there's a lot you can do after concussion to improve your recovery, but it's often very difficult to get people to do that.
Hi, I had a question about back to the diet, and so I've been reading some research previously about dopamine and serotonin levels and how the gut biome plays a role in that, and it may have some links to dementia. What's your thoughts on that?
Can you tell what dopamine and serotonin diets are out there?
Gut biome.
Yeah, so a healthy gut biome with healthy levels of dopamine and serotonin levels have shown in some papers that may or may not have links to dementia.
I don't think the evidence is strong yet. I'm actually looking at a colleague of mine in the audience who's been doing reviews of this at the moment. She's giving me the eye, Dr. Miller. I don't think the evidence is there yet, but certainly gut biomes and the interaction with the brain, I mean, it's the latest thing, isn't it? So there will be research done that may, bring new things to light that we don't yet know, but I don't think it's known yet. Well, Dr. Miller doesn't think it's known yet.
Hi, this is more of a personal question. My mother has been recently diagnosed with transient epileptic amnesia, and my question to the panel is, we're all at a bit of a loss because it's a rare diagnosis. We've been told that it's not linked to Alzheimer's or dementia, it's something quite different, and it can be controlled by meds, and so they're just trying to tweak the medication she's on just to limit it. The family's at a bit of a loss on what to do. She's a very onto it 72-year-old woman who's been very active, and she's very proactive with doing all her Sudokus and just keeping her memory going. I guess this is a good opportunity for me to ask you guys, is it a progressive condition? And if you know anything about it, what do you know that could possibly help us out? The floor is yours.
I'm looking really hard.
Well, none of us are neurologists, so...
I was determined not to be part of the panel, but the first thing is that you have to be really careful with all neurologic diseases because it's a very personal element, and anything that any of us say tonight, you have to recognise that. Epilepsy actually is a symptom of something else usually, often a scar on the brain or something, and I'm sure the investigations have been done, but some disorders causing epilepsy are progressive, but others are not, and most are not actually. And so it's, and the treatment of epileptic disturbances like this is to treat the underlying epilepsy, and most of the time it's with medications which stop the short circuits in the brain. Is that, I'm actually not quite sure who I'm talking to, but...
What's really interesting is that she has poor sleep quality, but she's linked that to her age. But also in the last couple of years, her hearing hasn't been right prior to this diagnosis and these symptoms. And it was just interesting for me to hear tonight that hearing, which she's done nothing about, may be linked possibly to that, or is that more on the dementia side?
I'd be very surprised if they were linked.
Right, okay.
It's fair to say that none of us live in a bubble, do we? And all of our illnesses have got all sorts of interactions with the rest of our body and our family and our social life, and that's something that we're getting better at understanding. But epilepsy, in the way you're describing, is probably a fairly pure syndrome and with a fairly straightforward treatment, I think.
Thank you. Yes, panel, I've come across a number of books in the Auckland Library which make interesting reading out of the States, but they seem to be advocating gluten-free, dairy-free, sugar-free to get rid of the brain fog and reverse diabetes, and advocating exotic grains and coconut, but essentially there is underlying it a Mediterranean diet. But have you got any comments on elimination diets in terms of the brain function and memory?
I think that the research isn't there yet to support sort of very stringent elimination diets. I do wonder what people eat when you've eliminated all of that. Potatoes, baked potatoes, which is good. But for some people who do have terrible allergies, that can be very, very important to do those. I would think they're quite intensive and quite hard to do. It's got to be worth it. I seldom recommend people do things that are extremely difficult and interfere with your life a lot, because it can make you miserable, whereas the disease that you have might not make you that miserable. So, you know, it's always a risk and a benefit. What is the benefit? If the benefit's overwhelming and it makes you feel a lot better, it might be worth going down that path. But don't feel like you have to. And I don't think I answered your question.
Hi there. Your research that you've seen to date, was it worth recommending, like, more the younger people here? Is there any, like, vitamins or supplements you'd recommend people to take, like your vitamin B series or plant extracts or anything?
The best thing people of any age can do is eat a really well-balanced diet and to get their vitamins from the natural food that they're eating. Now, having said that, if someone is shown to have a vitamin deficiency, a vitamin B group deficiency, then that needs to be remedied, and it's not good to have that. But most people have vitamin levels in the normal range, and you get much more effective vitamin absorption and use from food than from supplements. Yeah.
There are lots of things that people in early life and in middle age can do to reduce their risk of dementia in the future. And they're about being very active, doing things that stimulate you, that make you use all the bits of your brain and look after your balance and look after the complicated neurological things that we can all do.
And also treatment for hypertension, diabetes, cholesterol. These are the things we can do in midlife.
Hi, just for mild cognitive impairment, what are the pros and cons of the use of antidepressants to help, like, mood and motivation?
Well, I'm not aware of any evidence for using antidepressant for improving empathy or improving motivation. However, if someone with mild cognitive impairment also have a depression, yes, I mean, that is the time. And there's a lot of overlaps between the symptoms of depression, memory problems, mild cognitive impairment. So if the person have depression, yes, I will suggest antidepressant, otherwise no.
Good evening. I'm interested to know if there's any connection being drawn between the onset of dementia and chronic stress, especially that which might evoke Salyer's third stage, exhaustion, and perhaps subsequent sympathetic dominance. Is there a connection between that and the onset of dementia or cognitive decline?
So I think that when you are stressed and exhausted and not sleeping well, then those things make it much more difficult for you to remember things. That's not necessarily related to an underlying dementing process. But sometimes it's very hard to tell. And certainly people in the early stages of dementia are very anxious because things are changing and they don't understand why. So it's often very hard to sort that out. But I guess the message is that if you are very, very stressed and not sleeping and all that, fix that first before you go and tell somebody that you've got dementia. Does that make sense?
Yeah, that makes sense in terms of diagnosing someone with dementia. I do think that stress is not particularly, chronic severe stress is not good for the body in general, and that it may set in chains and cycles that are not helpful for the body. So I think when we look at some of the things that look like risk factors or look like things that make people better, it is sometimes around the benefits of not being stressed and being socially engaged and enjoying exercise and getting general enjoyment. So yes, we you know, when someone's in the early stages of a dementia, it can be hard to untangle what's stress, what's anxiety. But in general, I think, and I'm very good at giving other people advice, not taking it, I think that chronic stress is definitely worth trying to reduce. It's not good.
Yep.
Kia ora. Bear with, just as the last two questions have caused me to reformulate what I was going to ask. With stress and depression and anxiety, I'm curious if we should be concerned, as I teach high school and we're finding more and more year 9s coming into high school have increased anxiety and things like that. And so I'm curious if we might be seeing dementia or other cognitive abilities begin happening earlier in life.
Well, just to the evidence from the UK is they've done some quite big dementia prevalence study. What they found is that they repeat the same study like in 20 years' time. The risk of developing dementia is actually reducing because of better healthcare, better nutrition, and all the modern living is found to be quite helpful for reducing the risk of dementia. Not answering your question about, of course, if someone is stressed, have anxiety, depression, we should look, have those treated as well. Not necessarily through medication, but there's a whole range of psychological treatment can be very useful for young people.
Yeah, I agree with that. And I, from the GP perspective, I don't quite understand what's happening in our young people, because there is much more anxiety and distress being expressed than I've ever seen before, more frequently. And I'm trying to take a very reassuring approach to it. I think that what we do is we pick into our children and say, oh, that wasn't very good, was it? Or how did you go at school? Oh, that must have been hard. So trying to make positive statements, and maybe you can get your kids to make positive statements about each other and about what's happening at school, so that they kind of learn a positiveness. And I think maybe we listen too much to our children. Nobody ever listened to me when I complained when I was growing up. But now we're right on to anything that could be wrong, and maybe we're in a way pathologising our normal adolescent feelings. But I don't know that so much. I'm just trying to take a sensible approach to what seems to be an epidemic. And in the university now, we have 1 in 4 kids in their first year having a major mental health issue. And that's unbelievable. So we are needing, we do need to put a lot more positive psychological messages out about growing up. We all blame it on the phones. This is what, is it because, you're online all the time and so you've forgotten how to talk to someone, and then when you go to university, suddenly it's not the same. You're not as resilient. But I think this is something that as we go through the next 20 years, we're going to have to see how that pans out into the adult populations and then the older populations. And I don't know what's going to happen.
No, I don't think we actually have a really clear understanding from the literature yet whether the association between anxiety, depression and dementia is cause or effect. Whether it's certainly commonly found in people in the early stages of dementia, whether that is like a response, to things changing that they can't control that induces a mood, or whether mood itself is a risk factor for dementia is still quite unclear. But it's a really interesting point, and I think, as Ngaire says, it will be interesting to watch over the next, well, not interesting, we'll see what happens over that next period, 20 years.
If you go on a coffee and tobacco diet,
Tango dancing.
So that question was, if you go on a coffee and tobacco diet, you'll never get Parkinson's disease? Is that what he said? And I do highly recommend dancing the tango, though, because that's a whole lot of complicated coordinating actions which have to be done precisely, and you have to interact with your partner in a positive way and keep time to the music. So that's got to be good for your brain.
This is quite a simple question. Is forgetting people's names a normal part of ageing? Because some people I might know quite well, and I come up to them and I think, oh God, or I've got to, introduce them to somebody else, and you think, oh, hello.
I'm going to pose a question. How many in the audience has had that problem today? There's your answer. And they're not all old, because I'm looking around here and there's a lot of young kids that put their hand up. So that's the answer to that.
Is it made worse that if you're probably thinking about other things, as women tend to do, you're thinking about other things, you've got a whole lot of other things going on in your brain, and that possibly will make you forget that. The other thing I want to ask, and it's a personal thing, is my children. I go through all my children's names before I get back to the one that I want to.
How many in the room do that today?
Oh, gee, that's
the percentage is lower, I have to say, but maybe half the audience haven't got children yet, so we'll put it down to that.
Hi, I'm not sure if this has been covered in prior talks, but there's lots and lots of apps and stuff that have been, costly over the years, supposedly to help with memory. Is there any apps that you do recommend for memory or, cognitive development?
There was some research done with the Dakin, is it the Dakin brain games? They've done a whole lot of research on those apps, but I can't think of any others. We're actually Ngaire and I are conducting a study at the moment with robotics and using an app in the robot to deliver a cognitive program. So that's just at a very early stage of research, so it's not out there to be bought or anything yet. But, it's like anything with dementia. We've got the drugs, we've got the vitamins, we've got the apps, we've got everything. And I think really whatever suits you at the time will help you, because an app for brain fitness is a good thing. Ngaire would just show me while we were sitting here. She plays Scrabble with her sister. She said, I've got to play my Scrabble game right now. It's my turn. I do the same. I do the same because I know that's important, as you know, with our ageing brains, that we need to keep those things happening. And Scrabble, and I do Upward, and lots of people in this room probably do similar. So there's no harm, but there's nothing. And you shouldn't go out and buy. There are apps that you can buy. I think there's one in Australia about $40,000. You know, to improve your memory, you buy module after module after module. But really, you don't need to. You just download Upward and you'd have the same effect.
Yeah. The actual evidence on the effectiveness of brain training is not, it's not compelling at all. People improve on the games that they're playing and the apps that they're playing. This is different from Scrabble. On the games that they play, on the particular tasks that they're doing, but the evidence that this generalises to their memory in everyday life is very poor. There was a good review done just a few years ago, and it did show that brain training that was carried out in a group where there were 3 or 4 people together and an instructor hovering over them showed some effect up to a maximum of 3 times a week. But in general, the evidence that it directly trains your memory in a useful way is poor. But I don't want to undermine the message that being mentally active is good. But yeah, I'd be careful. I don't have a app that I recommend.
I think if you want to choose an app, choose something you enjoy doing, have fun. Do you have fun with your apps?
I do.
Good, all right. Just checking.
I do get a little bit addicted to them, and I have to delete them from time to time.
Thank you very much. So we are running a little out of time. I want to say a few big thank yous tonight. I want to say a huge thank you to my team at the Neurological Foundation. We've had 17 events around the country, and it's been really amazing getting researchers out into the community. A huge thank you to the University of Auckland and the Centre for Brain Research, and also Brain Research New Zealand for helping us with the events that we've been running up in Auckland. A wonderful thank you to the Celebration Choir. We so enjoyed singing along with all of you, and when we're 94, hopefully we'll be singing as well as you all are. And lastly, Lynette, Ngaire, Kathy and Ngaire, a huge thank you. You had some really challenging questions to answer, and you did a really wonderful job because none of them were scripted. So please, can you all join me in welcoming, thank you.